Good afternoon and welcome to Johns Hopkins Department of Pediatrics Grand Rounds. We have a great panel today on COVID-19. All right, so our panel today, we will introduce each of our speakers on the panel in a few moments, but really focusing on COVID and the impact on children, families, and practices. A topic I know that you've all been thinking about. Just wanted to also let you know that we have other grand rounds coming up. We always will be doing our COVID and pediatrics update. Next week, we have the Schwenker Award Lecture by Rachel Alinsky, a wonderful fellow here at Johns Hopkins, who's going to talk about substance use disorders, another important topic. And then in the future, on May 4th, we will do a COVID and pediatrics update, and then have a panel that's going to talk about management of COVID patients in adults. And it says to be confirmed, but it is now confirmed, and it should be a great session. And then the rest in May, we will be also doing our COVID and pediatrics updates, and we'll tell you what those other grand round speakers will be. So today, we have some speakers to talk about the impact of COVID on our communities, on our practice, on kids. We're going to start with our COVID update, talking about epidemiology and infection control by Anna Samuels. She is one of our assistant professors in infectious disease here at Johns Hopkins, and you've seen her face every week. After that, it's going to be talking about COVID and its impact on pediatric practice, and we have Maria Brown, one of our alumni at Hopkins, who will be talking. She is the president of the Maryland Academy of Pediatrics, and she will be talking with Jim Rice, another one of our community pediatricians, about the impact of COVID on pediatric practice. Followed by Latoya Mobley. She is one of our stellar social workers in the Harriet Lane Clinic, and is always caring about the families and children in our practice, and we'll be talking about resources and impact on families. And then finally, will be Carissa Parrish, and she is one of our psychologists here at Johns Hopkins Children's Center, who will be talking about the impact of COVID on mental health and also resources that we can all use. So thank you all on the panel for joining us, and thank you all in the audience. And why don't we get started with Anna?
Hi, everybody. Happy Monday. I'm happy to be talking with you today. I hope you had a nice weekend, and I hope you are feeling healthy and well. I'll start off with some of the numbers. I'll share one of the articles that has made a splash in the past week, and just some infection control reminders. So looking at the cases per percent of the population, the US is bolded here. Our overall positivity growth rate is slowing down a little bit. Most recently, 5% increase per day with a doubling time of 15 days. I like to compare it to Iceland in the top corner in light blue. They have now plateaued. They're getting very few new cases. There's some other countries and areas like Hong Kong and South Korea that have plateaued as well. And so I like to try to look at things in a little bit of a positive light. So this is a slowing down of the positivity growth. We have getting near 1 million cases, but not quite there. This Johns Hopkins density graph shows where the hotspots are in red around the country, and this is accessible to everyone online to explore a little bit more. In Maryland, as of last night, we had over 12,000 cases, over 55,000 patients tested. The same counties remain with the higher density of cases in Prince George's, Montgomery, Baltimore County, then Baltimore City County. Looking at Johns Hopkins medicine facilities, as of the end of last week, our overall percent positive result was about 20% positive of all of our testing sent. there is a slight uptrend here in the percent of positivity of the test sent. Looking at the age distribution, green here are the outpatients, and each bar is decade of age. So the middle decades of life see the highest number of positive lab results, and the same pattern we've seen over the last couple weeks in the older decades of life, particularly 80 plus or 90 plus, more of those patients are hospitalized than the younger age groups. In pediatrics, in the 0 to 10 years, we've had, as of last night, 8 patients, and 11 to 20, 43 patients. None were currently admitted. Sorry, part of my numbers are actually blocked. 1 second. In all ages, a little over 100 patients were hospitalized at Johns Hopkins Hospital, nearly 260 across all the Hopkins hospitals, and about 1/3 of those were ventilated. This is a slight increase marginally from last week, not a major increase. We also have the ability to look at these positive cases. These are all cases, all ages, looking at their demographics. Our African-American population has a slightly higher number of cases than those among white patients. We also have a breakdown by patient ethnicity, Hispanic or not Hispanic, and an overall half and half of male to female ratio. And actually a slightly female predominance here, but in general, I think it's been about half and half. Looking at the same statistics, but looking at just pediatric age groups, and in this case, it's less than age 20. We have a relatively equal distribution between African American, other, or white Caucasian. It does seem to be a little bit of a higher representation of Hispanic or Latino ethnicity, and again, about half and half male to female. So in the past week, a big area of discussion has been population serology. And so looking at what percent of the population has a positive antibody response to the SARS-CoV-2 as compared to a positive nucleic acid or molecular test. This is a preprint study that has not yet been peer reviewed, but certainly got a lot of press in the past week. So in Santa Clara County, they did an estimate of a population seroprevalence. They had 3 sites where they advertised about this on Facebook, and they had 3 sites do drive-up testing. You would get a finger blood stick for a capillary blood draw. They did a lateral flow immunoassay by Premier Biotech on 2 dates, April 3rd and April 4th. Their unadjusted prevalence for seropositivities was 1.5%. Adjusting for the age demographics that showed up, they had an overrepresentation of middle-aged females. They estimated a seroprevalence of 2.8%. The tests that they used, they actually examined the test performance under different conditions. The manufacturer's report. They also, at Stanford, did their own analysis using known positive cases for positive controls, and prior to COVID epidemic for blood from negative controls. They had a sensitivity overall of 80% and a specificity of 99.5%. So very specific to this virus and this strain, but perhaps missing some cases with that lower sensitivity. When they estimated the overall population prevalence, accounting for the test performance, they got a range of 2.4 to 4.2%. For their area, this was about 50 to 80,000 people infected in Santa Clara County versus the known positive molecular tests of closer to 1,000. So this was about 50 to 80 times the number of molecular tests was estimated to have positive antibodies. When they also considered the number of fatalities in this region, they got a case fatality rate of 0.12 to 0.2%. And for reference, seasonal influenza has a general case fatality of 0.1%. So the general issues, of course, this seroprevalence estimate is dependent on the test performance. False negatives will underestimate, and even a few false positives, given the overall low number of positive results, will overestimate prevalence. But I think this, this population seroprevalence study does support our general expectation that there are many people out there with mild or no symptoms that didn't get a test, or depending on testing availability. And so there are many more people who were potentially infected and recovered that never really presented to the hospital setting. And so the overall prevalence of infection might be higher than those presenting to facilities. A similar study was actually done in a German setting, and I'll just kind of glance over it because it was in German, so this is through some translating efforts. But it was based in Gengelt, Germany. They studied 1,000 people from 400 households. They had 2% known positive by molecular test and 14% seropositive by IgG, with a specificity of their test of 99%. And their case fatality estimate was 0.37. And so a similar trend, obviously here they have a higher seropositive at 14% compared to the Santa Clara County was around 2%. They did have a carnival, I believe, in this area of Germany prior to this outbreak, and so they may have just had more widespread exposure. A few infection control updates, and before I turn the speaking over. So from a testing perspective, this has gotten a lot of discussion over the last 1 to 2 weeks. More patients will have preoperative testing of asymptomatic patients. If they are inpatient at this time, they're going to get an EPIC flag that they can be in COVID isolation PPE, but can remain in a non-negative pressure room. For outpatients, I just caution, because this is already coming up as a potential challenge, is that once that test is ordered, that patient has a COVID flag for them to be seen under COVID precautions. And so if they have any other outstanding encounters between getting the test result, those encounters are now flagged. The testing turnaround time overall will continue to decrease as more steps are able to be automated in the microbiology lab. Another update is people might have noticed that the purple top canisters are a little harder to find. On many inpatient units, the disinfectant now being used is a product called KBQ. I mentioned this last week, but here is a new visual that is up on the infection control website now. So it's coming out from EVS is making dilutions. We're using the red microfibrable reusable cloths. Don't throw them out. The contact time is about 2 minutes, and there's a Scan Me that you can look for a video on how to use this product. Some general reminders: physical distancing is still really important, so please do continue to keep your distance from your colleagues when you're at work, even if you're wearing masks. One of the other questions that came up a couple times this past week is, as more units are using Draeger masks, the Draeger exhalation valve doesn't have a filter on it, so we're actually suggesting you put a surgical mask over the exhalation valve so that you are still masking yourself from between yourself and the patient. The inhalation, so it's more about your germs potentially going to the patient rather than it's not, the Draeger will filter whatever inhaled air is coming in. It's important to continue to do hand hygiene prior to touching your masks. And one of the other topics that has come up is where you have more COVID units around the hospital in different areas, we're seeing COVID patients in more areas in general. And so there is no segregation of staff if you're seeing COVID patients or not. There is training and clear PPE usage for those caring for COVID positive patients, but the staff who are doing so, their whereabouts are not limited once they leave those units. And again, a reminder, please don't come to work even if you have mild symptoms. We know that especially younger and generally healthy people might have mild symptoms, so please be conscientious of that and do stay home even if you have mild symptoms. And with that, I'm going to stop talking. Thank you so much, and see you next week.
We will take questions at the end, or send it to us in the chat. So now I wanted to turn it over to Maria Brown and to Jim Rice to talk about the impact of COVID on pediatric practices. So.
Good afternoon, and thank you, Dr. Chang, for inviting me to speak today on the impact that COVID-19 has had on pediatric practices. I'm going to give an overview of what we're hearing.
Maria, you're on mute.
No, I'm unmuted. I'm not muted.
We can hear.
We can hear.
Yep.
Okay. So I'm going to give an overview of what we're hearing from our members and the response work that the chapter is doing. And then Dr. Jim Rice, the co-chair of our Pediatric Council, is going to elaborate on the financial impact that he has seen in his practice and some practice management resources that pediatricians will find helpful. In the past month, our work and our family and our social lives have been completely
Maria, I don't know if you can hear me, but you're on mute. I'm trying to figure out how to unmute you, but if you're able to unmute yourself.
I'm not
No,
muted.
we can actually all hear her.
We can all hear her.
We can hear her.
Yeah, I'm not muted. Okay.
Keep going, Maria.
Okay, sorry. So again, all our lives have been completely upended by this pandemic, but pediatric practices have been hit especially hard during this pandemic. So next slide, please. Next slide. Next slide. Can you advance the slides?
I think she can't hear you.
Okay. So first, the nature of the pandemic with no surge for pediatric patients has resulted in an unexpected decrease in patient volume for such a widespread infectious outbreak. We really just simply did not anticipate this. Go back, please. 2 years ago, the chapter did a pediatric disaster preparedness needs assessment for the chapter, as well as focus groups, and we have been pushing out FEMA preparedness materials to members and working with the Maryland Department of Health and the Maryland Emergency Management Agency to advocate for preparedness materials to members and for a children's disaster cabinet. But really in none of these discussions did the scenario come up where children were disproportionately unaffected. And then also with the combined mandates on social distancing and requiring that kids be kept home from school, preventing other common childhood illnesses. So while the media has been rightfully focused on sobering images of sick adult patients in crowded hospital wards, little to no attention has been given to potentially another potentially devastating aspect on our healthcare system, which is the threatened viability of pediatric practices, which are of course the backbone of child healthcare. So doing a huge part of the normal work of pediatrics has been a challenge. Well visits and immunizations have been challenging. A problem as the crisis rolled out was that AAP and CDC guidance on well visits immunizations was not released before MDH gave its directives on physicians completing well visits. So now, fortunately, AAP and CDC are now encouraging pediatricians to prioritize well visits and immunizations for infants and young children through age 2 whenever possible. We are hearing some concern from pediatricians that some families may be hesitant to bring in their children to the office for immunizations. And if this becomes pervasive or continues, then we do become at risk for other infectious outbreaks. So it's really critical for us and other public health officials to continue to maintain our vaccination rates in children. Pediatric practices have also had to majorly transform their physical spaces. The first picture on the top is a picture courtesy of Monique Burke, our Secretary Treasurer. Their indoor waiting room is empty because all patients are waiting in their cars. Their practice is doing testing. As you can see, they're doing it in their cars, but they're doing it in their cars. Our sense is that practices are not doing a large amount of testing, and I know MDH is working on making its VEIP testing sites accessible to young children. The rapid pivot to telehealth visits has been tremendous, and again, something not that we discussed in our disaster preparedness scenarios, when it was thought that telehealth would really be typically done for communication between pediatricians and subspecialists who may have been inaccessible due to conditions related to a natural disaster or hurricane. Practices' ability to quickly adapt to this technology has certainly been key in determining revenue during these initial first weeks of the crisis. We have heard from some pediatricians who are seamlessly transitioning, while others have actually found it very challenging. Many have commented that telehealth gives them a unique window, though, into their patient's home, and they find that valuable. You keep going back, keep on going back. Keep going back. One key problem with the telehealth visits is getting well visits covered for older children. Some private payers have begun to cover these, but Medicaid MCOs, we've been struggling with getting guidance from them about making sure that pediatricians can get paid to do both parts of the visit. One, the history part now, and then in months after the crisis abates, to do the physical exam and immunizations then, again, for older children. So it is really important that pediatricians be able to continue to do these telehealth visits for older kids because we need to be able to continue to screen children, especially in our most vulnerable families, for food security, for domestic violence, for child abuse. And what we know is that children are not in school now, they're not in other social programs, so eyes on kids are decreased, and reporting of child abuse is likely to suffer for that. So we're advocating for pediatricians to be doing those. The lack of personal protective equipment has been a problem from the get-go, and we have heard from pediatricians who have struggled with this to make sure that they are keeping not only themselves, but of course their patients safe. Now you can advance the slides. So can you advance? Thank you. So as a chapter, what we're doing is we have been working hard to speak with the media on these issues, writing op-eds, letters to the editor, making calls to TV stations, et cetera, and working with our policymakers to make these issues on practices well known. We have been working really closely with our public health partners at MDH and other medical societies like MedChi, which has been a fantastic partner during this epidemic for us, and of course with National AAP and our leaders there. We have been also connecting pediatricians to new commercial vendors manufacturers which have pivoted to manufacture PPE, to connect pediatricians to them, and to also help them through the little bit of an onerous process that was to request PPE from the Strategic National Stockpile. We have also been doing weekly interactive webinars through our Infectious Disease Committee, and also practice management webinars. You can advance the slides. So I just want to make everybody aware about a few resources that we have on the internet. Our MDAP website is kind of like a one-stop shop for COVID-19 web resources. Our staff has done an amazing job compiling those and maintaining them up to date. National has a COVID-19 discussion board for pediatricians, which is also very helpful. Please reach out to our staff, our board of directors, our pediatric council, as well as our committees if you have questions or concerns. I know that I have here that Hopkins has created some talking points for general pediatricians. There are sample practice protocols that Jim Campbell University has assembled. And then also, I really want to just let you know that we are partnering with Rachel Thornton to do an access to care survey, and that should be coming out in the next few weeks because we want to be able to get better data on all the things that are impacting practices and your ability to care for children. And all these resources are available when you look at the slides in slideshow view, just to click on the links. So I'm now going to turn it over to Dr. Jim Rice, who again is our co-chair of our Pediatric Council, and will be speaking to you about the impacts that he's seeing in his practice and some resources.
Thanks, Maria. Hi, can everybody hear me? Okay, great. Thanks, Maria. Thanks for sort of teeing that up and giving the general picture. So I'm a practicing pediatrician in Anne Arundel County and Queen Anne's County. I'm also a Hopkins pediatric residency alum from a few years back. The data I was going to present was just some data from my own practice that I think encapsulates what Maria was describing. I do co-chair the Pediatric Council as part of the Maryland AAP, which is a organization that helps work as a go-between between practicing pediatricians and payers. And so I've heard from pediatricians around the state that our data looks very similar to theirs, and that just toward the end of the second week in March, as social distancing began in earnest, we really began to see our in-office volumes fall precipitously. I'm part of a large practice that generally sees this time of year about 2,200 pediatric patients a week. We really started to see that drop right around March 13th. And you can see the numbers here in front of you. The black line at the top is total visits. The green line, if it shows up that way, are in-office visits. And the yellow line that you can see would be virtual visits or telehealth. So this just gives some raw numbers and a graphic depiction of sort of the decline of in-office visits and the rise of virtual visits or telehealth that I'll go into a little bit more. Next slide, please. So just our operational response, I think, was fairly typical to what other practices have done. We really, in record time, mobilized a virtual visit platform. Well, HIPAA rules were relaxed to some extent here. There are some HIPAA compliant platforms out there. The one I've heard used most commonly is the one we're using called Doxy.me. There's actually a free version and an upgrade with a paid version that's really not too bad in price. I think about $50 a month per provider. It's a nice platform that's really worked pretty well. So we, what would normally be a 6-12 month rollout of telehealth was done in about 24 hours. In the last slide, if you didn't notice, our first week we did about 60 visits and are now up to about 600 virtual visits per week across our practice. We have expanded to hours with that, so even our evening on-call time, we're generally sort of using virtual visits. The payers really, there definitely was some cooperation here between payers and pediatricians, and that the payers really very quickly pivoted to telehealth and relaxed the sort of coding rules around that. Certainly complexity when we deal with 8 different payers. There were 8 different ways to do this, and really chaotic as far as trying to figure that out quickly. But I would say in good faith, I think the payers did very quickly make this a platform we were able to use to stay in touch with our patients. We did what followed. As Maria said, AAP guidance was a little bit slow coming out. We had the guidance from the Department of Health to stop all routine medical care. Again, we sort of interpreted that vaccines for young infants is not routine care. This is care that needs to occur as critical care. So we continued to do that. We did have an experience in our office that on March 19th, one of our docs developed flu-like symptoms, was tested for COVID-19 and was positive. So that was early on and really caught us that, boy, we needed to be wearing PPE for all patients, well or sick. And so we started that immediately. She's doing fine, by the way, but was out for 2 weeks and is now back to work. But we do wear PPE for all of these, or surgical masks, at least, eye protection, gloves, down when possible for well visits where we're giving vaccines. We've had good parental response to this when we've basically closed 2 of our 5 offices. One is a clean office, so to speak, where we see only well visits. I think that's helped parents be a little bit more receptive to coming in to do these visits. We have another office devoted to sick care. We've pre-screened all our sick care with a virtual visit, so we kind of know what's coming in. Again, that first week as things were moving quickly, we were trying to screen folks in our normal triage protocol, and we'd get them in a room and find out, parent was supposed to be quarantining at home for a COVID exposure, and, we weren't prepared for that. So at least using a virtual visit to screen people, we kind of know what's coming in before we're standing in front of them in the exam room. We've done limited COVID-19 testing in the office. We did some, but have been able to utilize the drive-up sites, which seems like a better use of resources, and we can maintain our office for the care I've described. This week and last week, we've really started now to target outreach to medically complex patients. As it's been a month of not routine inpatient in-person care, we're really worried about some of our medically complex patients that all of you care for at Hopkins, and we're really trying to use our EMR to pull lists of patients with medically complex needs and to target them for at least for virtual outreach. Next slide, please. Financially, this has been Armageddon for practices. We are there've been the analogies where like with the Walmart of medicine, right? We're high fixed overhead, low margin, remaining viable depends on the high volume I described. I mean, our practice does 110,000 visits a year. When that drops in half, it's just, practices have, honestly, with accounts receivable of about 3 weeks, we've got about a month to 6 weeks to survive before we really can't pay the bills. So that's a very short cycle, happens very quickly. and practices really still are threatened. I hear it, in pediatric counsel from practices around the state and around the country are really worried about our continued existence to be able to be there for our patients. Quickly to go through a couple of resources practices are relying on. Obviously, the telemedicine payment has been critical. You can see from my slides, it helps fill some of the gap, but we're still at total volumes about half of normal. The revenue per visit is lower for telehealth, even though there's payment parity. We are not really seeing the same kind of revenue we would see from WellCare, and we've got lots of adolescent vaccine sitting in our fridge, which is really sort of cash tied up for us as well, trying to make ends meet. Loan programs such as the Paycheck Protection Program and the Economic Injury Disaster Loan Recovery Program have been really sought out by pediatricians. The PPP program is now out of money. Some practices have received that, but others have applied and have not gotten it. Some HHS stimulus money went out on April 10th. All of this, none of this went to pediatricians. It all went to Medicare providers only. This was based on Medicare fee-for-service payments over the previous year and was a grant rather than a loan. So really wonderful to help keep adult primary care practices in practice, but pediatrics has not benefited from this. We're hoping that there may be a second wave where pediatric practices see some of this. Medicare is doing advanced payments, and Care First has announced that it will as well, but no details on that yet, and we're waiting on details and on money. Many practices, including mine, have had to furlough some staff, both providers, nursing staff, support staff, as we're at about half of the normal demand. There's really worry about longer-term practice contraction and layoffs, and for our practices not being there, sadly. I wanted to point out two resources. Of course, the AAP and MedChi has been wonderful. Jean Ransom's been helpful in advocating for pediatricians, Maria with the AAP as well, and that's been, I think, a great source for pediatricians in practice. I know this PMI forum. PMI is the Pediatric Management Institute. All of you may not know about it. This is a group run by Paul Evancheri and Chip Hart that supports independent practices. I mention it because they've done, for the last 4 weeks, have done a Thursday night webinar attended by about 1,000 to 1,200 pediatricians across the country, and has become just a really useful forum for finding out about both operational and financial issues for pediatric practices. I'll stop there and turn it over, and I'll be available for questions.
Good afternoon, everyone. So I'm going to talk about the impact of COVID-19 on families. So the true impact of COVID-19 is not yet known. However, over the past several weeks, we have begun to see the foundations of many of our Baltimore families rocked and shaken to their core due to the unintended consequences of this pandemic. As you can as you can see from the slide here, Maslow's hierarchy of needs also shows that the physiological needs and safety and security needs of families are the base of a person's foundation.
This is stupid. They'll get it. They don't need this. I'm writing it like anything. It's just stupid and redundant.
I know.
Tell them you talk to me and I don't see the point. Okay. And if they can come up with a really good reason, maybe we'll consider it, but we're not going to.
That's fine.
I think people have to mute their phones.
Sorry about that, everyone. So as I was saying, Maslow's hierarchy of needs that we all learned about in Psychology 101 just talks about people's basic needs, and the physiological needs and safety needs that patients need are breathing, food, water, clothing, health, and employment, all of which are threatened by COVID. So the impact of many families in the Johns Hopkins Children's Center, along with the ambulatory clinics, have many of our families have existing socioeconomic barriers to health pre-COVID. The onset of COVID has magnified these barriers in an unimaginable way. Families are very resourceful. However, they are experiencing limited access to services due to the stay-at-home order. So some of the limited access issues that we are dealing with are food. Families already live in food deserts, and widespread food insecurity is a problem in Baltimore in general. Due to the panic and bulk purchases, families are calling the ambulatory clinics and the hospitals stating that grocery stores have low to no stock of groceries that families can access. So families are calling the clinics and saying that there is no groceries on the shelves, and then also they are unable to afford groceries due to financial strain. Another thing we have to consider is that children who are at home 24 hours a day also puts an extra strain on families because of the fact that some children used to eat at school for breakfast and lunch. Now they are required to eat at home, and families do not have the resources to support the increase of need. Another thing that we're concerned about, commodities, diapers, wipes, and toiletries. The families are calling in and are unable to afford these resources due to recent furloughs, sudden loss of income, and the need for diapers and wipes is definitely going up. Families are also the WIC program. The majority of our patients utilize the WIC program to supplement infant formula on a monthly basis. And as you can see, WIC is closed, and so is the Department of Social Services. WIC is working remotely. However, what that means for families is that they have to send in applications via email or text message to the WIC offices, and then wait for about 1 to 2 weeks for a card to come in the mail for them before they can access benefits. In the meantime, infants are then struggling to have infant formula readily available. And this process, again, takes 1 to 2 weeks. So families are very concerned about that. So one of the things that I have listed on the impact slide is about medical care due to families' fear of COVID. And I heard a couple of people mention this before. Many families are calling in and stating that they are worried. CM Children's medical practice in Harriet Lane is often like a home base to many of our families. They present for acute care, as well as mental health concerns and high-risk social needs. They are very concerned about coming onto the medical campus due to COVID-19, and therefore are feeling very disconnected to the services that normally help them get access to things and also mental health support. So that is a really big concern. So I'll talk about resources in a second. The last thing is educational tools. As we know, all of the schools are closed down. They are using electronic devices, online platforms for children to get access to their education. More than 50%, and I'm sure the number is even higher. I was looking for the rates this morning, but more than 50% of the children in Baltimore City do not have access to Wi-Fi at home, nor do they have electronic devices. So this is a large, widespread problem that they are unable to access their lessons on a daily basis. In addition to that, like my colleague mentioned prior, schools, we heavily relied on school social work and nursing to report child abuse and neglect at home. And now that children are no longer in school, we are seeing a decrease in those reports. And that is highly concerning. We don't know what the overall impact of that is going to be. This graph right here I know I keep touching my mask, I'm sorry guys. It keeps sliding. So this graph right here is from the Hopkins Community Connection Desk, and it shows the open needs from March the 1st until April 15th. As you can see that typically for commodities, and commodities include things like requests for diapers and infant formula. Typically around this time frame, it would be about 75. Right now for open needs as of the 15th, we have 111 open requests for assistance with diapers and infant formula. If you look at the food graph or the food bar, typically we would have about 30 families per month requesting assistance or linkage to food pantries. And you can see that it's at about 136 families at this point. So families are certainly struggling in the areas of basic needs, diapers, formula, food, and other issues. So this slide just kind of shows the unintended consequences of the pandemic on children. It talks about their education, poverty, etc. For families who are already stretched, this is certainly a problem. So let's talk about the response. As it relates to children's medical practice and HLPC, one of the things that we are very proud of is that we've been able to form these multidisciplinary teams to work on patient outreach. So under the leadership of Dr. Julia Kim, we have formed a team that includes a social worker, mental health consultant, the acute care physician from Harriet Lane, and we have made a OneDrive document that we are working on. The medical residents have been asked to send an email or Epic inbox regarding all the patients that they are concerned about that were previously on their panel. And then we are working together as a team to outreach to those patients to see if they have their basic commodities, food, or if they need to do a televisit and are fearful of coming in. So that includes weekly outreach. And that effort is just starting, and we're huddling every week to make sure that all bases are covered. In addition to that, the clinics are increasing telemedicine visits with patients and families who require medical follow-up, and the ancillary service staff are joining the physicians in this effort. So we're seeing a certain increase of families who want to do telemedicine visits. Some of them don't have electronic devices, and for those, they are willing to come in. But we're seeing we're able to sign families up for MyChart. We're having our medical or CMAs to reach out to the families prior to their visit to help them navigate any of their electronic issues they may have. So the next thing is, I mentioned earlier that grocery stores have low to no stock, and that we are having an issue finding formula and groceries for families who do have the resources to purchase. So our Harriet Lane and CMP community health worker and the maternal infant case manager, Tracy Carter, are actually working through a list of grocers and other stores that they can call and see if there are any, see if there are any items available. And then the Hopkins Community Resource Desk is answering calls outbound and inbound to do resources as well. And then the last thing that is our response is that there's a weekly social needs huddle between CMP and HLPC, along with the Hopkins Community Connection team, so that we can discuss action steps every week. And that way we can know what we need to do for families and patients. The last thing is the resource slide. Oops, I went too far. Oh, can you go back one? So the last thing is the resources. So just back again. And just to let you know, there are like the Hopkins, on the Hopkins website, there is a list of resources that includes food, commodities, school resources, and multiple things. There's a link there, and it's on the Hopkins website. The Public Health Institute or Urban Health Institute also has resources that you can link to your patients. It's a 14-page document on the Hopkins website. And then my personal favorite is Sesame Street in Communities for Young Children. Parents can utilize this to take up the space that is at home and teach children to wash their hands, etc. If you need any assistance in linking families to care, please reach out to your unit social worker or your clinic social worker and the Hopkins Community Connection team. Thank you.
Hi, can you hear me?
We can.
Okay, great, thank you. I wanted to start with a brief quote from an article that came out in the Lancet about the impact of the COVID on mental health in kids. The United Nations estimates that 1.38 billion kids are out of school or out of childcare due to stay-at-home orders. There's not clarity about when things are going to go back to normal, and many of us working parents are trying to balance the needs to support our patients but also support our families. And there are a lot of potential mental health challenges at this time. You can advance the slide. The multiple sources of stress are the education transition, as we've mentioned, the economic strains and food insecurity that Toya was summarizing, and the social isolation and loneliness that kids and their families may be experiencing. I had just an informal survey from my daughter's 4th grade class. I had a public comment during the first week of the transition to online school. And their ELA teacher asked them to identify the top feelings in their families with the transition to online school. And my daughter and I did a, on-the-fly psychological descriptive study, and we found that the top answers were lonely and sad. The kids also, just as a side note, did a mindfulness exercise, and everyone identified feeling more relaxed and more calm. So we'll talk about mindfulness in just a second. Something that a lot of us in the mental health world are concerned about are pre-existing behavioral and mental health problems, and how those are going to come to a head with increased friction being at home with their families, and also with parents having to transition roles and become teachers as well as parents in a more pronounced way. Things in our psychology group that we've talked about, kind of general concerns that are going to be potentially exacerbated during this time are increased parenting stress from multiple sources. And as Toya was mentioning, and I think Maria as well, there are the implications from kids being under kind of house arrest with their families for such long periods of time. There have been prior studies that have shown that violence and vulnerability increase for kids during periods of school closures that are associated with health emergencies. So there could be increased rates of physical abuse or other types of child abuse, and that's something that we're hoping as a kind of a Hopkins community we can kind of mitigate through a variety of resources that I'll mention. If you could advance to the next slide. For families with a healthcare worker or an essential worker in particular, I think one of the things that I think about as a psychologist, especially being a child psychologist, is the impact of social media and kind of unceasing news attention on the coronavirus, and how much kids are being exposed to media information, for either what type of media information or the duration, quantity of media information. There's also within families with healthcare workers or workers who are essential workers, concern for infection for parents. And then within our healthcare community in particular, kids who have parents who are staff or healthcare workers working in COVID positive units can be particularly stressful for kids, as well as parents who may be caring on those units may be isolating themselves, and how difficult that is, let alone having a parent actually become infected and the worries associated with that. So we can go to the next slide. The parenting stress that we're dealing with is normal stress plus extra stuff. So you can see here. So now we have all of the regular routines, and there have been, if you need a lighter note, a proliferation of very funny COVID memes around parenting and how challenging it is. But the regular things that we all deal with, plus now having to run a homeschool environment with, you know, a range of kind of social capital, as Toya was mentioning. So even though not all kids have internet or Wi-Fi at home, for Baltimore City Public Schools anyway, a lot of these lessons are now being broadcast on television. But as all of us know, that is a far cry from like a normal social educational experience. In addition, for parents, managing this work-life balance, trying to run a full-time homeschool while also trying to make some semblance of home. You can go to the next slide. So we have these wonderful resources, and I'm sure everyone has been availing themselves of just a ton of resources, but I wanted to highlight two in particular. This time of hardship, there's also a time now to get back to the basics and kind of reviewing what are the most effective things that parents can do to support kids and also support themselves. I'm going to show you just a couple of these examples, but UNICEF has put out a series of evidence-based positive parenting approaches to supporting kids and supporting themselves in their parenting role. And beautifully, they are available in a ton of different languages. So we can go to the next slide and look at the first one. So this is the example for the one-on-one time, which I'm sure my pediatric colleagues, you guys are preaching this all the time as a part of just regular parenting, anticipatory guidance, just the one-on-one time. The other thing that I've been doing that I'll talk about a little bit later too is how we can use some of these basic parenting things as a way to practice mindfulness as the parent, and also promoting mindful support of children. So if we can go to that next slide, we'll see that the UNICEF resources include parenting, managing stress, mentioning things like taking a breath, doing some body scan, focus on the breath, some basic mindfulness techniques. And go to the next slide. So I've compiled a list of these resources. I think the slides are going to be made available later, so maybe you can take a picture with your phone just to kind of get the contact information if you want. But these are all the child mental health services through Hopkins. So the first one I listed is our pediatric psychology group that I'm the co-director of. We're taking new referrals from the community, and all visits at this point are telehealth, which is true across the child mental health clinics within the Hopkins system. We're also trying to prioritize a separate intake for kids of staff members. So if there are, employees that you work with employees, people reaching out for mental health services, we're going to try to prioritize those. So if you encourage those families to contact us, just let them know that they should let our intake person know that they are a child of a staff member employee. The Bayview Community Child Psychiatry Program is also taking in new patients, as is our Child Psychiatry Mental Health Clinic over at KKI. They're also taking in new patients. The CMHC has been reserved for the step downs from our acute services, which have been continuing. And we are seeing some kind of secondary effects of the COVID quarantine on mental health presentations due to parent-child conflict. And so we still are caring for acute psychiatric patients. We can go to that next slide. I just wanted to have like a brief highlight for the child psychosocial team within the Children's Center and how we're trying to support both pediatric patients, kids whose parents are hospitalized, but also kids within our community of Johns Hopkins Medicine Children of Staff. And I've highlighted here, I highlighted in red so that you could see what the different articles about. These are different resources that our child life, social work, child psychology, and pediatrics colleagues have posted on our Hopkins Medicine website. So how to talk to kids about COVID, resources for COVID, stressed about COVID, coping with COVID stress, and just general resources. We could go to the next slide. I also wanted to highlight that for our staff, employees, and colleagues, the adult psychiatry department has started a new service specifically to provide mental health support for adult employees. And you can see there's a hotline that's being staffed by volunteers from within the psychiatry department. We can go to the next slide. So we have a couple of mindfulness resources. The first one is led by Netta Gould. So impressively, she has been leading mindfulness meditation sessions via Zoom 3 times a day for half an hour each. And all employees are able to access this through a Zoom group. And then 2 weeks ago, we started branching this off into a 30-minute mindful parenting session. And we're hoping to be able to offer that throughout this time. We can go to the next slide. Just wanted to have just a quick summary of mindfulness. I'm sure a lot of you have heard about mindfulness, and I think one thing for us as pediatric providers is to try to prevent burnout, as this is going to be kind of a marathon that we're continuing for a while. So just a brief summary of mindfulness is paying attention in a particular way, kind of focusing in the moment on purpose and without judgment. This is something that as providers, we can be kind of pausing in between patients or in between Zoom conferences that are going all day long just to try to preserve some emotional well-being and centeredness. Thank you.
That was terrific. And we are open to your questions, but wanted to just mention, oops. If your questions aren't answered today, our Pediatric Incident Command Center is open daily. You are free to contact, anybody is free to contact us by phone or by our email address there if you have any questions about COVID management. And our Hopkins Access line is there. And then we have many resources, as has been mentioned. This is our website where we have COVID resources listed there on the tab. And wanted to also mention there is a COVID-19 activity book, as well as some infographics. That my favorite one is, when you cough or sneeze, where should your germs go? Into your elbow, on your hand, on your friend. But anyway, so we are open for questions. I was going to do that at the end. If people can unmute and ask a question, or we can take them from the chat. We'll do both.
So it looks like for those of us in private practice, can someone comment on whether rashes can be presenting a sign of COVID? We are seeing lots of unusual looking rashes and reading that in elderly rashes can be associated with COVID.
Hi, this is Anna. So I think there have been some kind of case reports or case series about microthrombotic events in adult patients. And so that could present in some ways as a dermatologic finding. However, at this time, there's not a clear description of any particular rash associated with COVID in pediatric patients that has been well described or recognized, or that we've recognized so far. So I guess, though not impossible, it hasn't actually been described in a clear way.
Hey, did someone ask, is mindful parenting available just for the staff, or is it available for parents in the community to Zoom into?
Thanks, Dr. Parrish. So right now we're doing it for Hopkins employees and staff, and we're trying to figure out a way to manage launching that within kind of like outside of the Hopkins walls for patients.
What are pediatric practices doing about providing Facebook or other platform events to address food insecurity, dental needs, physical activity, mental health, mindfulness, etc.?
So there is a team that is working on trying to have the ambulatory clinics more visible on social media platforms, and we should have that going soon. In addition to that, with the outreach, we are giving parents the links to different activities, and we also are linking them into mental health and telehealth.
Is there a place to donate formula or diapers for the Harriet Lane patients if I have families who have excess and have outgrown it?
So we would say to donate the diapers to Share Baby, which is the local diaper bank. Formula, we would take it from like staff or resources, but we would not be able to take formula from a home to Harriet Lane. So all of those items can be donated to the Share Baby diaper bank, and they can be found online. And then we get our diapers from Share Baby.
I can mention something about the Facebook platforms, et cetera. Our practice has a fairly vigorous social media presence. Our docs and nurse practitioners have been reading bedtime stories to kids at night to try to keep a familiar face out there. And I'm due to record mine this week, so hopefully it goes well. But that's been a way to engage some of our families, and hopefully we can round back around to maybe some questions about food insecurity and other care issues once we've kind of engaged that platform out there.
Perfect. I know there were a lot of questions earlier on, and it seems that many of them were answered along the way. So maybe we can take one more question if someone's question was not answered.
Yeah, hi, this is Dr. Lala. Children with milder symptoms, respiratory fever, cough, how long do they have to stay? I have an 18-year-old who works in a nursing home, and she had symptoms of fever, cough, and sore throat. And so the question is, should she get tested or should she stay home, isolate herself? For how long?
Hi, so just summarizing, there's a case question here of an 18-year-old, so this would qualify as an adult patient who has respiratory symptoms, who is actually a healthcare worker. So in for our patients, this patient would be tested as an adult who is a healthcare worker with more than one symptom, yes. And then in terms of guidance, as a healthcare worker, the individual occupational health guidance would have to be followed for that institution where she works. the general guidance that the CDC offers is patients should stay at home for at least 7 days from their symptom onset and at least 3 days from resolution of fever and improvement in respiratory symptoms. So sometimes, that is a little bit hard to really tease out with people. But in general, they at minimum need to stay home for at least 7 days, and their symptoms should be resolved or improving.
So she should be tested then. Yes.
Yes, she should be tested. We would not want, there have been, as you know, outbreaks in nursing homes, and it would not be good for her to have symptoms and be going back to work.
Okay, thank you.
All right, well, thank you so much for joining us. We have heard from our clinicians, our social workers, that we should finally wrap up by listening to one of our patients. So enjoy this video and have a great day, but hope you enjoy this video.
Don't worry about a thing, 'cause every little thing is gonna be alright. I woke up this morning on my horizon. 3 little birds were on my doorstep, singing sweet songs, melody blowing through. And they said, this message is you. They said, don't worry about a thing, 'cause every little thing is gonna be alright. Don't worry about a thing, 'cause every little thing is gonna be alright.
Thanks for joining us.